Good evening, everyone. It's wonderful to see you, although I can't really see you that well from up here. I am Nicole Macri, and it is just wonderful to have this time together with you all tonight. Welcome to Mission Possible, Adaptive Solutions to Homelessness. I'm going to moderate tonight's discussion, and I'm just really delighted and excited to have this panel of experts up here with me. We're going to tonight talk about innovative and compassionate approaches to addressing homelessness and addiction in our community. So you all, there are papers on the seats that you sat on. So there are bios about, that describe our presenters tonight, and there's some additional materials that we'll talk about. And before we dive in, there's a few key points I want to highlight for you. Number one, everyone deserves a place to live. And I think if you're here tonight, you probably agree with that. It's, I think, also important to note that a home doesn't take away all of our challenges, and so people still have struggles once they move into housing. But without housing, those struggles are really exacerbated. And that housing with built-in supports is really essential for a thriving community. So the other handouts under the bios will talk a little bit about some of the topics we're going to talk about tonight, including, what is harm reduction, what is housing first, and a bit about candidates. So we're in a particular season right now, election season, and so wanted to provide you with some information about what to look for in candidates related to issues around homelessness and housing first, and what are some common misconceptions that we hear so that you'll be ready to engage in those discussions. Okay, and before we start, I'm just going to make a really soft plug. So I have worked at DESC for a long, long time, and I am very passionate about the organization. And also on your seats is a donation link, QR code. So if you feel moved after tonight's discussion, I just encourage you to contribute to DESC. Your contributions support the mission of our organization to provide stable housing and essential services for people in our community. Every single dollar does really make a difference to help people regain their footing in our community and rebuild their lives. So take a look around the room for those. Okay, so now I'm just gonna start with introductions, and I'm gonna turn here to my right and ask Daniel to introduce himself.
Hi, everybody. I'm Daniel Malone, DESC's Executive Director.
Oh, hi, everyone. I'm Seema. I thought he was going to say more. I'm Seema Cliff-Asefi. I'm an associate professor at the University of Washington Harborview Medical Center, where I co-direct the Harm Reduction Research and Treatment Center.
Thank you.
And I'm Kelly Ryder. My pronouns are she, her, and I am the director of King County's Department of Community and Human Services.
And my name is Jeremy Hogue. I am the nurse care manager for our opioid treatment team at DESC. He, him pronouns.
Thank you all for being here. And each one of these panelists have a unique connection to DESC, and they'll talk a little bit about that as they answer questions, right, y'all?
Yeah.
Okay, so I'm going to start with the first question. What are the most common misconceptions about homelessness you encounter in your work? And how do these misconceptions impact our community's response to homelessness? So why don't we start with you, Seema?
Okay, great. So I'll just also mention that I have been working with DESC as a researcher since 2006, so going on 18 years, nearly 2 decades. A lot of the work that I have done involves people experiencing homelessness or with the lived experience of homelessness who also use substances, really trying to identify ways for people to reduce the harm that they're experiencing from their substance use and figure out ways to improve the quality of their lives. And I was responsible for being part of the evaluation of 1811 Eastlake, which is DESC's sort of primary single site, initial, I should say, single site housing first program in the country. So DESC has been leading the way around harm reduction and housing first, which is also affectionately dubbed as harm reduction housing. Your question was about dispelling the myths, and I think one of the myths is that homelessness is primarily due to addiction. So I want to really very quickly dispel that myth and talk about how that narrative is deeply flawed. It oversimplifies many of the factors that contribute to homelessness. While addiction can be a factor for some people, it is not the primary cause. Homelessness is driven largely by structural factors, the lack of affordable housing, economic instability, social and racial inequities that disproportionately impact marginalized communities. And in many cases, addiction is a consequence of homelessness, not the other way around. People often turn to substances to cope with trauma, stress, the isolation of being unhoused, and blaming addiction as the cause really ignores this larger systemic, these inequities, and perpetuates stigma and a false narrative. I also want to just, because I'm a researcher, I'll give you some actual percentages, not that I can see any of you there, but the research shows that roughly 20 to 35% of people experiencing homelessness have a substance use disorder, but that means the majority of people do not. And so that is a really important distinction. And then furthermore, 30 to 50% of those who struggle with substance use disorder also face co-occurring mental health issues, so have a severe mental illness. I think that is something that is largely ignored. And what I have learned and my colleagues have learned from years of working with people experiencing homelessness or with that lived experience is that things like poverty, untreated mental health conditions, job loss, the rise of the cost of living, lack of affordable housing, all these granular level factors are some of the drivers of homelessness. And just to let you know, most Americans are between 1 and 2 paychecks away from losing their housing stability. So just think about that for a moment, and then consider all of the myriad of things that come along with that. So just to close up, to truly address homelessness, we really have to focus on the structural barriers while also providing at the same time access to mental health and addiction services. And I know we have someone from King County here who can speak to that. We need compassionate, evidence-based solutions that will tackle the real issues driving homelessness. So thank you.
Thank you for that. So Daniel, do you ever hear about misconceptions about homelessness?
So while SEMA provided some of those data about substance use disorder not being the primary driver behind homelessness, DESC specifically focuses on serving a group of people who struggle with substance use disorder and serious psychiatric conditions. And one of the misconceptions that I find myself hearing a lot and talking with people about is that what needs to happen is these folks just need to be brought into treatment. They are not accessing the treatment that would change things for themselves. And one of the studies that SEMA's group led with us that really dove deep into the backgrounds of the people that we were serving, looked at treatment participation among folks with substance use disorder who were moving into our housing, and documented an average of 16 prior treatment episodes for these individuals. And to me, that says a couple of really important things. One is that they want to be better. They're continually attempting to change their circumstances by going back to this thing that they've been told they need and that they have been told will help them, despite the evidence from their own experience that it hasn't worked super well for them. And then the other thing that it tells me is that we need much better kinds of treatments, because it's not the kind of magic treatment car wash that we're all looking for, that we could just run people through and at the end of it, they'll come out nice and shiny and things can proceed from there. That's, unfortunately, it doesn't work that well. And so, yeah, I'll stop there.
That's great. Thank you. And Jeremy, you're working directly with clients, so anything to add to this?
Yeah, I think a couple things that I took away from this was that certainly substance use, which is where I really focus my efforts, should not inhibit the ability to get housed, right? That we talked about the reality that there's multiple factors, right, that are really impacting somebody that's living homeless. And just because you cure or change or, treat substance use or you treat mental health isn't necessarily going to make them a better fit or, for housing. It's just really important that they have housing so that they have access to resources. I mean, housing really is a gateway, and especially at DESC where we provide a lot of other services. So when people get housed at DESC, now they have different options for substance use treatment. They have different options for mental health treatment and those kind of things, even medical treatment. And treatments that are really tailored to the population that we are working with. And I think that's something that DESC really offers, is just this unique tailoring of treatments of various kinds to individuals.
That's a great segue into our next question. So let's talk about how DESC's harm reduction approaches differ from the conventional approaches and what benefits come out of that. And before we delve into that question, Seema, I'd love to turn to you as our expert to help define, what does harm reduction even mean?
So thank you for that. So harm reduction is really a set of compassionate and pragmatic strategies that meet people exactly where they are and helps them reduce and mitigate the harm that they may be experiencing due to their substance use or their relationship with substances. And so just so we can agree on definitions there, and as I mentioned before, DESC operates from a very harm reduction perspective. Their housing first model is dubbed harm reduction housing. I know that Jeremy is going to talk more about DESC's specific approach, but really it's about, you'll hear that tagline, meeting people where they are. So it's not about our traditional abstinence-based models in substance use treatment are really focused on abstinence-only approaches, whereas harm reduction is really centered on mitigating the harm that people are experiencing, from their substance use, as well as their communities, the larger community and their community and social networks. So figuring out ways to reduce those harms and also on the corollary, improve the quality of their lives. So I'll pass it over to you, Jeremy.
Yeah, so what does that look like at DESC, right? People have different ideas about how to apply this. We talk about mitigating harms. I don't think there's probably a bigger harm to mitigate than death. And, we look at 2023, King County unfortunately lost nearly 1,400 community members to overdose. Way too many of those people were known to DESC, right? A population that we serve. So when we look today in, say, our opioid treatment program, we may not be able to solve opioid use disorder, but what we can do is solve the overdose crisis. And how do we do that? We do that by a medication that we have the opportunity to offer and to treat people with. And I think I'm going to talk a little bit more about that later. But the ultimate form of harm reduction is for us is really stepping that down, is reducing your risk of overdose death, right? And reducing the harms that come with substance use. And so you hear a lot in the media about, especially in the past, what is harm reduction? Harm reduction is handing out sterile syringes, things like that. For us, harm reduction really is about improving the quality of life, reducing your risk of fatal overdose. So really solid things, really tangible things, which we have actually been able to do. We've seen tremendous change in the numbers at DESC this year, and I'll get to talk about that a little later. But I think the other piece that Seema and I were talking about that is really integral to harm reduction is, we can read off what it is, right? We can talk about it. There may be principles that whatever organization you come from implements, but what it really is a belief. Because if you don't believe in the principles, right, if you don't believe in the administration of a way to do things, it doesn't work. We work with really, really smart people that know when somebody's not telling them the truth, that knows when somebody's working with them that's not authentic, right? So I think at DESC what's really phenomenal is getting a chance to work with so many people that believe in the message, that actually allow us to connect with a population that otherwise probably other clinicians couldn't connect with, right? And for us, I think that's really what underlies harm reduction.
I just to add to what you're saying, I think it's really the spirit behind how you connect with that person, I had one other thing to say, but it left my head, so I'll say it if it comes back.
That's great. Thank you. That is so great. Sometimes I've heard people say, Jeremy, you alluded to it, that harm reduction is about handing out Narcan or clean needles, but really at the heart of it, harm reduction is about engaging with somebody to think about how they can be involved in reducing harm that happens to themselves, to their community. And that engagement only happens when there is deep trust and rapport. And so that is the key to it. So I really appreciate both of you speaking to that. Okay, so it's been quite a few years around here in Seattle. We have had a lot of shifts in the environment. So there was a bit of a global pandemic that hit us and everyone else in the world, certainly had a disproportionate impact on people experiencing homelessness. And as Jeremy, you just spoke to, there's been an extraordinary increase in overdoses and overdose deaths in our community. And we are seeing, of course, and our community has been talking for quite a while about increased crisis in behavioral health, not just among homeless individuals and families, but across the board. We're hearing about this in our public schools and in our hospital emergency departments. And these dynamics have certainly impacted DESC and the people that we serve significantly in the past few years. So Daniel, maybe you can kick us off by talking about some of the adaptations that DESC has implemented in response to these changes in the environment.
Great, thank you. So DESC's always been a crisis response organization. We were founded to respond to the crisis of street homelessness and bring people indoors in whatever condition they were in to provide them a measure of safety. But over the years, we became aware that the best thing we can do for people is to provide them with permanent, safe, supportive places to live. And that's where we have prioritized our efforts for quite a few years now. And then along comes all this stuff Nicole's talking about to really slam us hard. Not only was there all this unmet need in the community that we were facing along with everyone else, but the things we already had going on were struggling more than they had been before because people weren't doing as well as they had been before. So First thing was we had this big congregate shelter that we had continued to run for all this time because we didn't have enough housing yet for everybody, and realized this virus might come along and sweep through and kill a huge portion of the people because it was populated by people with really serious health conditions. And working with King County in particular and others, we responded to that so fast. It's the fastest I've ever seen any major movement happen, where the county rented a hotel and gave us the keys. We didn't even sign a contract for that. And we just moved everybody into non-congregate spaces. Our staff went down there and we started running this property like never before. And we've needed to make other adjustments along the way of these last few years. None of them have been that fast, though, unfortunately. So we're doing a ton about the overdose crisis. But we've lost a lot of people because things have been too slow in coming with that. But we'll talk more about that, Jeremy in particular. We'll give you some good information about that. And we've managed to implement some new things, some of which are still emerging to respond to more of these incidences of psychiatric crisis that we continue to see. So we've really had to adjust a lot to make sure that we didn't just leave the crisis stuff behind, we doubled down on the crisis stuff. One piece we're working on right now that we hope to be able to make announcements about soon is a new shelter, emergency housing kind of place, non-congregate, but aimed specifically at this group of people who today we see in different forms of states of crisis. We help them stabilize, but we don't have anywhere for them to go after that because everything's full. And so we're working on this kind of engagement type shelter for people with really high needs and feeling like we're about to accomplish something with that. Meanwhile, we're still committed to the true permanent change that is going to make all the difference in people's lives ultimately. So we've got 4 permanent supportive housing projects in development right now as we speak. 2 of them are under construction, actually. And those are the things that are ultimately going to be the permanent fixes to these things, but we've had to be flexible and adjust to the immediate problems that have just been right there in our face.
Thanks for that. And Jeremy, can you speak a little bit about what those adaptations look like on the ground in your work?
Yeah, for sure. One thing about working, in my experience in the last 4 years working here is for an organization that is often under-resourced and working with a difficult population and just always kind of up against it, I would say that one of the things I have seen is just an amazing reaction to certain things. We have, I think, being small and with people that are really passionate about the work, we have the capacity, and I see it, we actually can make change really fast. Not as fast as we would like, but for instance, in the last year, I said that I'm the nurse care manager for our opioid treatment program. Last summer, summer of 2023, we had a new medical director come in, and this individual, Dr. Waters, is also an addiction medicine specialist, which when you work at the opioid treatment program is really great for you. He comes in with a lot of amazing ideas and just this wealth of knowledge. And we spent the last year in response to the overdose crisis, we spent the last year, calendar year really, from September to September, making incredible adjustments to the way that we were delivering medication for people that use opioids. For anybody that doesn't know, we prescribe a medication called Suboxone, which was an oral medication that individuals had to take every single day, sometimes 4 times a day, and every day to be truly effective. And this is really difficult when we think about the population base that we work with, right? And our success rate with that, we have people come back and connect with us over the years for sure, and there were successes, and I don't want to undermine that every success is extremely valuable, but it was very limited, right? It's not a method that works very well. And when Dr. Waters came in, we got a chance to move towards what we call a long-acting injection. So we have a medicine now that we can give every 28 days in an injectable form. So we really just need somebody to find a good day or a day that they can connect with us in a period of maybe 4 to 6 weeks. And, before, maybe we had some kind of retention rate of maybe 25% when we were taking films or the medication every single day. In the last year, we are upwards of near 80% of people continue to come back. And
Wow.
And the thing is that needs to be understood is that I mentioned before that the medications we have, this medication in particular, if they are on this medication, knock on wood, none of those people have overdosed. Not a single overdose. And that is remarkable when you work in the landscape that we work in, right? That is those numbers and the retention rate and people coming back and people continuing to get medication. These are people, many of these people are unhoused, right? And come to a clinic and go through a process with us that's a little difficult. Getting on medication is very, very difficult to do. And if it's not done with great care, these people go into what we would call precipitated withdrawal. It's a severe form of withdrawal, and in the past, what happens is they just return to use immediately in the moment. But through the work that we've gotten to do with our medical director over the last year and the adjustments that we have made, we have landed in a spot where our methods and our protocols are actually leading the community, and people are coming to us and we're sharing our methods and protocols, and it's the softest landing place we've found for people. And obviously nearly 100 people in the last calendar year have been part of this, and almost a large majority have come back. So that is a direct response, right, to the overdose crisis. And that is the kind of thing that we can do. And I'm not sure, when I talk to community partners like Harborview, and they're just like, we wish we could do what you're doing. We wish we could do what you're doing. And they're moving towards that, but they have to go through all this, all the protocols, all the logistics of making that happen. And meanwhile, they literally will just call and they're like, Jeremy, can you take this person? Can you take this person? Can you take this person? Or whoever's in the office for our program, right? So it's a really unique position to be in, but that's been our adaptation. So
That's amazing. So as you heard Daniel mention, we can't do this alone. We need strong partnerships, and one of our most key partners in the community is the King County government. And you heard about how quickly King County pivoted. And I do say every day I'm so grateful for King County for getting us through the COVID-19 pandemic. I would prefer to live no other place in the world than in King County during a global pandemic. Yeah, for sure. Kelly Ryder, as you heard, heads the Department of Community and Human Services, which administers human services across our region, including behavioral health, homelessness response, and affordable housing. So Kelly, I'd love to hear a little bit about King County's role in all of this during this time of change.
Absolutely. And I think you heard a lot from Daniel and Jeremy about the work that we have partnered on together. As you said, those partnerships are so valuable, and the thing that comes to mind for me is, I don't go quite as far back as Seema is working with DESC, but I think I've been working with you all since 2011, and even then I knew that your value set was to say yes when it matched your values. I've been able to see that so much more in my last 5 years with DCHS, because DESC, when we have had a program that we've said, we know we can fund this, now who will do it? So many times, you are the only organization that says, we know this needs to happen, and so we're going to figure it out. And so that work that you're talking about, Jeremy, the work that we've been able to do in response to COVID is only possible because of that ability to say yes. Some examples that come to mind for me, the work to be able to move folks to a non-congregate setting in a hotel was certainly incredibly valuable. We at DCHS and at the county a few months back we announced that we had 13 actions we wanted to be able to take to address the opioid crisis. And so we created this long list of things that we knew could make a difference. So many of those are in partnership with DESC, the work that we continue to do on mobile crisis teams, the work to open new opioid response. And really, I think, Jeremy, what you speak to is the fact that right now it feels like there is hope.
So much.
It feels like we are actually able to point people towards access and treatment that actually match needs. We are not nearly at scale that we need, but we've been able to open a hotline for people needing buprenorphine. We've been able to open a new 16-bed residential treatment facility for folks with both mental health and substance use challenges, and we keep trying to do that next step. I think the biggest thing that we at King County have been able to learn from over these last few years, recognizing the impact of our behavioral health crisis, is to be able to pass a new levy, a new funding source called the Crisis Care Centers Levy that has a variety of things that it funds, but most importantly will open walk-in treatment any time of day, urgent care style, the same way that if you break your arm, you need to go to the emergency room, you can do that for physical health. Our vision is that we need to be able to do that for behavioral health. And a lot of that, thank you, and I provide that applause back to you all, as I imagine many of you are King County voters. But much of that is based in what DESC has been doing for years through the Crisis Solutions Center, recognizing that you haven't been able to do that for everyone who needs to walk in, but really understanding that for folks in crisis, we need a place for them to go. We need a place for people to turn to that's going to match their needs and be able to see them for who they are and lower their barriers to getting care that they need. So those are a few things that King County's been working on in partnership with you.
Wow, thank you. Okay, so Kelly and I have the good fortune to talk about a policy quite a bit, particularly in my job outside of DESC. And so I want to turn back to you again, Kelly, and think about from a policy perspective, how can we support evidence-based, compassionate approaches to homelessness and addiction? And I think this is on people's mind right now as we're thinking about choosing our next batch of elected leaders. And so your insights into what's on the horizon and what we can be working on is, I think, really timely and important for us to hear about.
All right. Well, I will certainly give it a try. And there's a long list, obviously, of stuff that needs to happen, the details of which I will defer to folks with like DESC. But when I think about the kind of general areas where we need to make progress, the places where we have really seen the most need to move forward is around setting priorities, putting out the funding, and then being able to site the buildings. And the last thing that I will note, just a little thing, is actual staff and workers to be in those buildings. Which is certainly not a minor thing. So we, I think, have over the last few years seen a tremendous change in people being willing to prioritize addressing the needs of folks experiencing homelessness, particularly those with behavioral health conditions. Addressing that priority means something different to different people. But even being able to get it on the list of things that we need to prioritize, I think has been a huge step forward. Many years ago now, I was working on the Seattle Housing Levy in 2016, and I had a resident look at me and say, I just wish people would have told us a few years ago that affordable housing was a problem. And so I wish that that's where we were, but we are prioritizing this now as a community. The second step then I think is funding it and bringing it to scale, and we've seen some progress in that, certainly not at the scale we need, but things like the Crisis Care Centers Levy allow us to kind of keep pushing forward. We have seen something that I've never seen in my career here in the last couple of years, especially with the pandemic response, new federal funds flowing through, that for the first time we have had funding available and we haven't necessarily been able to deploy it effectively. And I think a lot of that has tied to two things. One is being able to site buildings and have people welcome permanent supportive housing, treatment centers, on down the list of opening doors that people need in order to access care. And the other thing is making sure that we can have the quality, representative, robust workforce that we need in those buildings to provide that care. And so I feel like we're making progress on those things. We're finding some options, but it certainly starts with communities themselves being willing to say yes to these buildings open. And then we are also always trying to find new ways to recruit workers, to be able to pay workers a living wage so that they choose working in housing and homelessness, to be able to keep bringing things to scale.
Wow, thank you for that. Okay, so as we're thinking about political candidates who would truly support housing first and harm reduction, Seema, can you talk a little bit about how research can inform policy?
Sure. I have been very privileged in my career to work on 2 large-scale evaluations that have informed policy on a national scale. I didn't get into psychology to impact policy in my very early days as a young 20-something-year-old, and I've been so incredibly grateful that the work that I've been able to do, one with Housing First, particularly in partnership with DESC for these past 2 decades, really evaluating low barrier, non-abstinence-based housing as a public health approach. And being able to speak to those results. I've testified in legislative sessions. I have been invited to the White House, along with Ian over here, who's sitting in the right in that front seat, to talk about another evaluation, another Seattle innovative program, first known as Law Enforcement Assisted Diversion, now Let Everyone Advance with Dignity, where people who were suspected of low-level drug offenses and sex work were diverted out of the criminal justice system into harm reduction case management services, where they were able to actually get the support that they needed to be able to, get connected to employment opportunities, get connected to housing. About 80% of the people that were in that evaluation were actually experiencing active homelessness at the time of their arrest. And so both of these, through being able to speak directly to the research, has informed policy. In 2009, I believe, Housing First was adopted as a best practice in federal policy. I'm not sure what year that was, 2016, I believe, where we spoke to Obama's White House, I will say, and shared the results of the LEAD evaluation. I know that's been adopted by many, many states. There's a map on the LEAD website that shows all the areas where that program has gone into effect. And so it's been really exciting to be on that end, to do the work as a scientist, as a researcher, and then share that result with the general public. So just translating science to the general public has been my true honor, and I'm very happy to have been able to contribute to those 2 large-scale projects.
Wow. Well, thank you for that and for your incredible work. So I want to make add a few more comments, and as I mentioned, there's some handouts on your seats. But just a few things to think about as I think everyone's ballots arrive today or should be arriving this weekend. So when you're assessing a candidate and thinking about this issue of homelessness or addiction, some things to look for. I would say, do they understand? Have they communicated that they understand that Housing First is an evidence-based practice? Do they know what it is? Do they know what the strategies that work to address homelessness that really work? Do they recognize that housing is a basic right, that you really, as a person, can't address your basic needs without having a place to live? Do they understand that housing shouldn't be a reward for abstinence or compliance with treatment? Do they emphasize the need to get people quickly into housing, regardless of their situation? Do they acknowledge the role of harm reduction and understand what that means? And are they committed to investing in the strategies that work? Strategies like supportive housing, are they willing to stand up in the face of opposition, like Kelly talked about, to get the strategies that work actually implemented in our communities? And like, do they know who DESC is and what we do? So these are just some cues for you, some clues as you're making your decisions about your vote this election season. And you know, we hear a lot of things right now about some misconceptions, and some of them were up on the board before. You know, one, I'll say I hear a lot about are, you know, housing is really expensive. I talked to a Seattle Times reporter this morning, and she was interviewing me about the governor's race and like, what should we look for in our next governor in terms of addressing homelessness? And you know, I reflected to her, like, I have talked with a lot of elected officials over the years, and almost all of them are like, yeah, Nicole, I know we need to do housing, but it's so expensive, it's really hard to cite, takes a really long time. Like, what can we do now? So look for elected officials and candidates who understand we've got to do things with urgency now, but we also have to do the hard work. There's no shortcut to the work that we need to do, and that in fact, the alternative is a lot more expensive for taxpayers than providing housing for folks. And Seamus referenced this nation-leading research that she worked on at the 1811 Eastlake Housing First building. You know, in that project, we saw hospitalizations go down. We saw alcohol use decrease significantly. We saw nearly everyone, 95% of people stayed housed. This was a population of folks who we were told were, quote, unhousable. And it costs a lot less than the alternative. It actually, the cost offsets were more than the entire cost of operating the program. So if we had not given people the housing, we spent more on them through emergency services, law enforcement, hospitalizations, jail time, et cetera. Okay. So now let's kind of start to wrap up here. So I would love to hear a little bit about, you know, what all of these folks who've been paying attention to us for the last almost an hour here, you know, what are some concrete ways that they can support this work, either, you know, DESC's work directly or to the long-term solutions that we are all looking for in our community?
Well, in terms of direct support for DESC, thank you, because you're here and you're already doing it. The money we raise at events like this and through other donations fill these gaps that we have. We've got very complicated financing for the work that we do, dozens of government contracts. We get health insurance reimbursements for some of the healthcare services we deliver. We collect rent from our tenants and get rent subsidies in the door. And none of it's enough to cover the actual cost of doing everything. Contracts have restrictions on what they will pay for and what they won't pay for. So private dollars really help us close those gaps and fill in to allow us to keep the lights on and do the work that we do. So thank you so much for participating with us in those ways. There's some other ways you can engage with us directly, and that includes volunteering in different ways. We can set up volunteer opportunities for you and your colleagues at work if you want to do something like that. We could set things up for you to do at your workplace or come into one of ours. We do sometimes outfitting apartments. Sometimes we call them apartment adoptions. We've got new apartments that we're opening on a somewhat regular basis, and we have opportunities for people and groups to come in and convert those apartments into homes for people, outfit them with the stuff that somebody moving in is going to need, and putting some real signs of welcome into those. So we'll have one of those next year available. And then other kinds of volunteer opportunities, people coming in and serving coffee and just being present. The expression of kindness and dignity that provides to the people that we serve is really beyond our ability to measure. It's critical that people feel like they belong in a community, and having volunteers come in and provide them that kind of connection to others in the community is really invaluable. So those are a few of the things that people can do to support us directly, and thank you for participating in any of it.
Yeah, thanks. And so Jeremy, you shared information that I wasn't aware of until tonight. That is great. So do you have other thoughts?
Yeah, I'm thinking about the conversations I have with my mother and some of my family about the work that I do, and how I explain that. There's a little note here that says, highlight the importance of educating others and challenging misconceptions. And I think that it's more about, for me, it's about finding a really authentic way to talk about the population that we're talking about. So when we're challenging misconceptions about, homelessness, when we're challenging misconceptions about substance use, I think that on its surface, a lot of those challenges, when we're trying to, quote unquote, educate somebody, become debatable items, right? Debatable facts. Well, and people kind of have a response to that. What I think that I would like to share in this area is, can you find a way to talk about this population as human beings? Can you find a way to talk about, like for me, do you know, like if you've ever seen somebody go through withdrawal from opioids, what that looks like and why people don't stop? Do you know why people use? That in people that are really struggling with use, that they're typically treating physical pain, or they're treating mental trauma, right? Or they're, whatever it is, right? All sorts, they're self-treating, because we live in a society, in a world right now, it's not even our society, but we live in a world where we don't necessarily have great options for mental health treatment and for substance use treatment. It's kind of a guess still. It's like, take this, that didn't work, let's up the dose on that, right? The way that we gauge success is by feedback from these individuals. And I was thinking about the treatment thing, right? Treatment is, people talk about treatment all the time, right? This idea of abstinence and going to treatment. The thing about treatment that's so kind of devastating is the way that we talk about treatment is from the perspective of all the people that have succeeded. So we've taken all these people and we've worked backwards and said, this is what they did, you got to do that. So if you're a sports fan, right? Well, this is what Tom Brady did, you just got to work backwards, right? Or this is, what this all-star pitcher did, you just got to work backwards and you're going to get there. But we know, right, that a very small percentage of society will ever achieve that kind of success. And the reality is with substance use is it's very, very difficult, and there isn't a one-size-fits-all. And that's what we do well at DESC, right, is individualized care. But I think to really do that, drawn back to where I started this, is can you speak of people with substance use disorders as human? Can you talk about maybe what it is that they'll struggle with, what that life looks like? What does fentanyl use look like compared to heroin use? It's terrible. You got to use like every hour, right? It's just miserable. It's a miserable way to live. It's so difficult. But can you find that? Or what it's like to sit with somebody who's hearing voices that's untreated, right? Like when I start sharing those stories with like my mother who's a right-wing conspiracist, like, living in Arizona, her best life, she's like, oh, okay. So that's what I think about when I think about this education piece, right? Is getting personal, making a connection, not arguing, but really pointing out that they're not, nobody that we're working with is winning. They're not winning. They're not taking advantage of anybody at all, ever. In fact, they've been taken advantage of their whole life, by a system that doesn't know how to treat them. And usually they got there often by backstories that will keep you awake at night, right? And that's what we're doing every day. So I think finding those ways to communicate with people. So.
Yeah,
Yeah, thank you.
that's a good way to.
Yeah. All right. So Kelly, what do you have to say?
Yeah. I'll totally follow up on that.
Yeah, right. No pressure.
I think that that's obviously totally spot on. And I think of public engagement like a Yelp review. Government hears from people who don't like what we're doing, and the people who actually think it's a good idea very rarely communicate about it. And so, my only addition is to take what you're hearing tonight and think about who else needs to hear it. Think about where you can help expand the conversation. DCHS does have some communication tools out there. We do have an Instagram account. And we have some very cool people who are not me that actually figure out what to put on there. But we also have a blog, dchsblog.com. And so those are some places where you can see about DCHS's broad work. What I find is that King County does a whole lot. Nicole talked about the reach of our agency. We like to say we do cool stuff, and very few people know about it. So we keep trying to find channels to be able to say, actually, there is funding available for behavioral health treatment. And actually, we have opened these things up. But the time that people actually reach out to us is when we're about to support opening a building in their neighborhood. So I don't need to repeat myself. I will say one of our esteemed county council members is in the room and following up on what your county council, your state legislature, all of those things are doing. Because as much as we need to scale what we're doing, our governments in King County and the region are doing some really cool things to advance, and we've just got to keep up the work.
Yeah. Thank you. So I think I actually see two county council members here, and so I want to.
I was worried that I was not
we
seeing
can't really
everybody.
see from up here, but I want
Very
to
hard.
acknowledge them. So Councilmember Jorge Barone is here up front, and I think I see Councilmember Rod Dombowski back there in the back. So thank you both. And do we have other elected officials here who I can't see with the lighting?
That's better, thank you.
No, that's great. Thank you for that. Thank you both so much for being here. And to this point, I wanted to share a story I shared with Jeremy.
There is an elected official right here from the fight in 43rd.
Yeah. I shared a story with Daniel and Jeremy when I first came in this evening and I think it's really important to share stories like this. So a few weeks ago, I got a text from a friend of mine who said, my husband and I have become friendly with a guy, and he's been living unsheltered on Capitol Hill for a really long time, and he's really deep in his addiction. And today, for the first time, he said he wanted to stop using, and he wanted to get some help. And we don't know how to help him. I don't know who to text, so I'm texting you. Can you give me any tips? And so I said, I probably actually am not the best informant, but here's my idea. Why don't you go over to DESC's Hobson Place Clinic. This is a health clinic that DESC runs in partnership with Harborview. It's an integrated clinic where DESC provides the behavioral health care, and the amazing doctors and nurses from Harborview provide physical health care, and they do it in a coordinated and seamless way. And I said, Hobson Clinic takes drop-ins. They have triage staff there, so just say you want to talk to triage or intake and see if they can help you. So she said, okay, worth a try, thank you. Last night, she texted me at 8:30. She's like, oh, hey, Nicole, I just wanted to give you an update about our friend. He's living at Hobson Place Apartments. And he's been there for a week, and he's doing amazingly well. And my reaction was like, literally I wrote in the text, what? Like, how did that happen? And she said, you know, a social worker who was doing street outreach had talked with him weeks ago about moving into Hobson, and he was reluctant. He had been thinking about it, and he decided he wanted to do it, and we helped him get there. And her comment was, the system is working. And I think, you know, even I was in disbelief, and when I told the story to Daniel and Jeremy, they both went, what? And so even us who are deep in this work sometimes are in disbelief when the system actually works as we hope and intend for it to. And so that just gave me so much hope that we are on the right track. And to Kelly's point, a lot of the amazingly good work we're doing is not so visible sometimes. So, you know, I just want to wrap up, see if panelists have any final comments or takeaways you think the audience should have from your wisdom here before we wrap up this evening.
People get better, and
Get better.
they get better thanks to getting support. So thank you for your support that allows us to provide support.